Welcome everybody to this presentation this afternoon. Pleased to have you here. I'm Jim Taylor. I teach philosophy here at Westmont, and the reason I'm here to introduce our speaker is that we were classmates here at Westmont back in the day. I was a graduate of the class of 78 and Dr. Swanson class of 79, and we were philosophy majors together at the time. Had at least one class together, and then he went on in sociology, and that's why he's here today. And let me introduce him to you, just letting you know something about his academic credentials and his background. So Dr. Jeffrey Swanson, Westmont class of 1979, is currently professor in psychiatry and behavioral sciences at Duke University School of Medicine. He holds a PhD in sociology from Yale University, and his current research is focused on building evidence for policies and laws to prevent firearm-related violence and suicide in the United States, and to improve outcomes for adults with serious mental illnesses in our communities. He's an author of over 200 academic publications on subjects ranging from the social environmental context of violence in psychiatric populations to the effectiveness of involuntary outpatient civil commitment and psychiatric advance directives. He received the 2011 Carl Taube Award from the American Public Health Association and the 2010 Eugene C. Hargrove MD Award from the North Carolina Psychiatric Foundation, both for outstanding career contributions to mental health services and policy research. Dr. Swanson has appeared on CNN, the PBS NewsHour, and I'll tell you, it is fun to be watching the PBS NewsHour and to have your friend show up on the screen all of a sudden, unexpected. MSNBC, CBS News, Bloomberg News, NPR's Morning Edition, and All Things Considered, and his research has been featured in the New York Times, Los Angeles Times, Washington Post, Time Magazine, The New Yorker, The Guardian, and numerous other international news outlets. Dr. Swanson served as a member of the John D. and Catherine T. MacArthur Foundation Research Network on mandated community treatment and the Methods Core of the Robert Wood Johnson Foundation Public Health Law Research Program. He's delivered invited lectures at numerous distinguished institutions of higher learning, now including Westmont College, and he frequently serves as a consultant to public policymakers at the national and state levels. Well, so his talk today is entitled Gun Violence, Mental Illness, and the Law, Balancing Risk and Rights for Effective Policy. Please join me in welcoming Dr. Jeffrey Swanson.
Well, good afternoon, everyone, and thank you so much, Jim, for the kind invitation to come back to Westmont. Thank you all for coming. It's really wonderful to be back on this campus and just to be flooded with all kinds of memories and that kind of, mix of sadness and joy and longing that you feel, about those years, which were very sweet. So today we're going to be talking about two very complicated, very important, but different public health problems, population health problems that just intersect on their edges. On the one hand, we have mental illness, these disorders that impair the brain's ability to reason and perceive reality and regulate mood and to behave in functional ways, do all the things that are so wonderful about being human. It makes it difficult to do many of those things. And we, have 10 million people out there in the United States who have suffering or are suffering from an illness like schizophrenia or bipolar disorder or major depression. About 3 million are not getting treatment. We probably have more people with serious and disabling mental illnesses in some of our big city jails, like the Los Angeles County Jail or the Cook County Jail, than we ever had in the largest asylum in the middle of the 20th century. And I think that's a scandal. The mental health care system that we have is fragmented, it's overburdened, it's under-resourced, it doesn't work very well for lots of people. It's a problem that costs our society over $300 billion a year by one economist's reckoning. So that's that problem. On the other hand, we have the problem of firearm-related injury and mortality. that claims the lives of 40,000 people every year in the United States and costs our society $170 billion a year. So we're going to talk about what these two problems, mental illness and violent behavior and gun violence in particular, have to do with each other. How they're not related necessarily, what we know about that scientifically, what we don't know, and maybe just as importantly, what we think we know sometimes that ain't so. And I'm a researcher, and I believe in trying to bring research evidence to bear on trying to solve these problems. I believe in evidence-based policy and in policy-informed research, so we need to be asking the right questions that could actually make a difference. But to do this in a way that will avoid just adding to the burden of stigma and social rejection that people with mental illnesses often feel when their neighbors believe that if they have a mental illness, they're dangerous and they're to be avoided. And to do so in a way that will respect the rights of lawful gun owners, because there's a constitutional right at stake. So that's our challenge today. For the next hour, I'd just like to invite you to kind of come along with me as we think through this problem together and maybe think a little differently about it. Let me start with this little diagram here. There's a circle that represents violence and a circle that represents mental illness. And you see there's an intersection in the middle. And I've just learned recently there is a name in spatial geometry for the shape that's formed by the intersection of two circles. And you know what it is? It's a lens, because the lens resembles the lens in the human eye. I think it's a really good metaphor, too, because if you imagine that you're standing over there in the gray circle where your concern is mental illness, you are, let's say, a mental health professional or a mental health system administrator, and you're looking over at violence, you're looking through that lens, and you're going to see the things about violence that are maybe connected to psychopathology or connected to mental illness, and you're going to miss, perhaps, a lot of the important aspects of violent behavior and aggression that don't have to do with mental illness. And likewise, if your concern is violence, and you're looking through the lens at mental illness, you might just really focus on the aspects of mental illness that might be connected to violent behavior, and not necessarily focus on a lot of the things about mental illness that have nothing to do with that. So if we think about this problem, imagine that we're trying to find out who are the people who fall into that intersection and have mental illness and also perhaps are at risk of harming other people or themselves. And so, we have this little device here. I'm going to call it a screener, right? See that box with a screen in there? Okay, that's the screener. That's a way of profiling people. And we say, here's the population that we have accessible to us. Let's ask them these questions, and if they come to a certain threshold, then we are going to say that they, are a case of someone who needs some intervention. And so the problem, of course, is we have the T plus and the F plus. That stands for true positives and false positives, right? So people who actually, we say, yes, this is the person who's going to be violent. Well, we might be wrong. In fact, we are wrong half the time. Psychiatrists are not very good at predicting that. But now we're going to do something with that information, right? So what if we do this? What if we say a person who we screen as being, a risky person with mental illness, they're going to be eligible for intensive services. Maybe they're going to be given an intensive case manager or put on an assertive community treatment team. Maybe they'll have priority access to treatment. There'll be some social welfare benefits. Maybe they'll get housing, and maybe there'll be a safety benefit for them and also for others. But what if we do these things too? We confine people. We deprive them of their liberty. We exercise social control. We stigmatize them. Maybe we discriminate against people. Now it's a little more concerning that half those people are actually false positives, right? And then we have all of what's happening in that circle, right? People who are violent, but they're not detected by our screener. They're not mentally ill, or maybe they are mentally ill, but they haven't been screened, or they've been screened, but they don't fit our profile of our, so we don't even do anything about them. And then we have these people over here who have mental health needs that don't have anything to do with violence. They're not screened. Maybe they are screened for violence, but we don't detect them because our instrument is not very good. They have other needs and risks. that have not been addressed. So this is kind of problematic. And then we ask ourselves, is this a good thing to do? Well, you know, if you read a book on bioethics, you'll read about principles like beneficence and non-maleficence and, you know, respect for autonomy and justice. And, you know, these are kind of variations on what you probably learned from your grandparents. Don't hurt people, and help others and protect others, and show respect and be fair and tell the truth. And, you know, if we're talking about my grandparents, probably, and don't waste money, right? Because this is an expensive thing to do. Okay? So just kind of take that frame there and put that off to the side in some brackets. I'm going to be sharing with you a lot of information today using statistics and pictures that depict statistical associations and phenomena and patterns. Statistics is kind of the currency of persuasion in science and research. But I like to remind myself that at the core of every statistic about human populations is a person, is a life. In some cases, a life that's cut short with loved ones left behind. A tragedy in its own right. That just rips through families and communities and over the generations. So I'd actually like to start with a person, not a statistic. Let me introduce you to Mr. T. Mr. T is 41 years old. He lives by himself. He has jobs now and then, you know, intermittently employed. He's a client of a county-based public behavioral health department. He's receiving counseling for a lot of different diagnoses, including agoraphobia and anxiety and depression. He has some paranoid symptoms, sort of excessive threat perception, thinking other people are out to get him. He's a regular marijuana user, and he's injured his back some time ago, and he's been prescribed an opioid pain medicine. He's been arrested one time, a misdemeanor drunk driving arrest. And he's got a lot of anger, and a lot of his anger is directed against the people who are supposed to be helping him at the mental health center. He's angry at them. And he's seeking additional attention and help, and his family and his girlfriend are concerned about Mr. T. Are you worried about him? Well, you know, if you're a mental health professional, you know, in a public behavioral health clinic, you have seen a lot of people like Mr. T. Probably see people like him every day. But let me just add one little element to the story here at the end. Mr. T is a gun guy. He frequents gun shows. He legally possesses a number of firearms. Now are you any more worried about him? Well, who is Mr. T, and why do I have his picture, and why am I telling you about it? Well, his name is Scott Harlan Thorpe. And he's well-known, actually well-known in Nevada County, California in particular, because he committed a really awful mass casualty shooting. He walked into the mental health clinic with a handgun and opened fire. And one of the people that he killed was Laura Wilcox. Laura was a college student who was working there, you know, as an intern, and she lost her life. Laura became the namesake for California's Outpatient Commitment Law, Laura's Law. It was AB 1421. It was enacted in 2001. What Outpatient Commitment does is it extends the state's civil commitment authority from the institutional hospital setting out into the community, and says a person who has an illness that might, if they don't get treatment, lead them to become dangerous in the future, that they can be issued a civil court order with a treatment plan inside of it that says they must follow treatment. And that law is very controversial, but it was enacted in California, and it was named after Laura Wilcox. Mr. Thorpe was charged with murder, and he was found incompetent to stand trial. He was so mentally ill, he was unable to understand the proceedings against him, and he was committed to a secure forensic facility. And he was restored to competency with treatment. 2 years later, he pleaded guilty to murder, and he was sentenced to prison. Laura's mom and dad, Nick and Amanda Wilcox, became very powerful advocates, first of all for Laura's law, but then they were advocates for another law 10 years later, and that was the gun violence restraining order law, giving the police clear legal authority to search for and remove firearms from someone who poses a really significant risk of harming himself or herself or someone else, even if they don't have a gun disqualifying criminal record or mental health record. And this was enacted in the aftermath of an incident some of you may remember, the shooting in Isla Vista by Elliot Rodger, who was a young man who was very disturbed, and his family were so concerned about him, they called the police to make a welfare check on Mr. Rodger, and they did, and the police determined he didn't meet the criteria to be detained and transported under California's 5150 short-term involuntary commitment law, and so they left him alone with his guns, and then he perpetrated this mass shooting. So here's some questions to ponder as we go forward. Did mental illness cause the shooting of Laura Wilcox? Is that the master explanation for it? You know, that mental illness is really the cause? And was the shooting predictable? Right? So should somebody have connected the dots and said, this guy is going to do something terrible? Even if it wasn't predictable, was it preventable? Should someone have been able to do something to prevent this shooting that would have saved the life of Laura? And who should have done something? The mental health system, the doctors, law enforcement? Should this shooter have been legally prohibited from purchasing or possessing a firearm? And here's kind of a poignant question too. Would Laura's law have saved Laura, if it had been enacted? And a thought experiment, if you were given a choice between, you could either have assisted outpatient treatment, mandatory community treatment, Laura's law in place, or you could have an extreme risk protection order law, which would give police the authority to remove guns temporarily from risky people. Which one would we prefer? Which one might have been better able to save Laura's life? Here's another story, just briefly. This is a case of Mr. H, a very different case. Mr. H was diagnosed with schizophrenia as a young adult, and he responded very well to treatment. He was stable for many, many years, taking antipsychotic medication. He was a gentle soul, and then something happened in his state. The entire public behavioral health system was changed through a managed care contract that privatized the system, and he got a different mental health care provider. He got a case manager who was not as highly trained, and he didn't see a psychiatrist very often. And this mental health clinician decided, well, maybe he doesn't have schizophrenia, and maybe he can stop taking this medicine, and maybe we can do another treatment. And what happened is that Mr. H suffered a very serious relapse of his psychosis. And he had a couple of emergency room visits. One time he came into an emergency department, and there was not a psychiatrist on call who could see him, who was available to see him, because they just didn't have the resources in the mental health workforce to make that possible. So they reached a psychiatrist on the phone, and they described Mr. H's condition, and he said, that's okay, let's discharge him. And part of the reason was that there was no bed available to admit Mr. H. In 2005, in a very severe psychotic state, he shot and killed 5 strangers. The survivors, the people whose loved ones had been killed, filed a lawsuit. And as part of that, the argument was made that perhaps the entire system of care needed to be put on trial, right? This was a problem of a system failure. So that's a question for you too. Was it mental illness, or perhaps was it the lack of capacity in this very fragmented, overburdened, under-resourced mental health care system that was partly responsible? So let's think about interpersonal violent behavior. I've been using the word violence, but what are we talking about? What does it mean? What does it look like? How do we define it and measure it, and how do we perceive it, or how do we talk about it? I'm going to read you just quickly several pairs of descriptions of things that might be defined as violence. And as I describe each of these pairs, think about three things. How are they different and similar in three ways? Do we need a different explanation, causally, for the first one compared to the second one? Or a different causal explanatory model? Or maybe the same explanation? And would we need a different or a similar intervention to try to prevent these? And then, how might they be related to mental illness or psychopathology? So here's the first pair. A young adolescent boy pushes a female classmate, in anger on the playground. B, a husband shoves his wife against their bedroom wall. Think about differences and similarities there. Two acquaintances get into a fist fight in a bar. An urban gang member shoots a rival gang member over a drug market turf dispute. A hospitalized psychiatric patient punches an aide in the arm. A recently hospitalized psychiatric patient randomly shoots several strangers attending a religious service. A new mother drowns her infant. A husband shoots his wife and two children before turning the gun on himself. A family annihilator is a term that's used there. A high school student scores 100 kills in a video game that simulates serial murder. And B, a high school student sends a text message to a classmate threatening to kill 100 people at their school. So I think what we need to realize is that there are a number of dimensions that form a kind of a scaffolding around our discussion of violence. These dimensions include severity. Some of these events are far more severe than others. Some are far more lethal. Multiple people die. In other cases, nobody dies. Are they two very different things? We have relationships. Some of these describe relationships where they have intimate partners, people who know each other very well, and others it's complete strangers. We have social settings, a hospital, a school, a public place. And the idea of motivation or intent, what is it that might be driving a person? Is this a sort of an instrumental, goal-directed, deliberative act? Is it a very kind of just an impulsive act, right? Something that's just very reactive in a moment. And, is there a mental state that's driving this? What about age and gender and life course development? There's, you can imagine an act that if a 12-year-old boy does it, it's very, very different than if a 22-year-old young man does it. Same behavior, similar behavior. And then cultural norms, right? This idea of symbolic violence. What is it when someone's engaging in violent acts in something like a video game? So, here's a really broad definition of violence that the World Health Organization promulgated. The intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group or community that either results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. Wow, that is really broad. There's almost, no human malady that you couldn't shoehorn into that definition, right? Here's kind of a definition that I have revised. It's a little more like what we usually measure. The intentional use of physical force or power to harm another person resulting in physical contact with the person or a threat to harm a person with a weapon in hand. Oftentimes, we're asked to apply research findings where the behaviors we are studying are things like pushing or shoving or slapping people. And we're asked to apply that to help understand a mass casualty shooting. And maybe they're really, really different things. One is very rare, the other is not. So how are mental illness and interpersonal violence related in human populations? Well, if we just went out and asked someone on the street in Santa Barbara, you would probably, hear an answer like, well, yeah, mental illness is, it causes violence. And a lot of the violence in society is caused by mental illness. And just imagine that you came from some distant planet and you learned everything you knew about schizophrenia by watching television in this country. That's all you knew, right? Just crime dramas or what you read in the newspaper. You would think, here we have the Martians watching the Earth Channel, right? And the Earth Channel is really frightening. That's what you think, because that's how mental illness is so often portrayed in the media. Public opinion polls tell us that 60% of the adults in the United States believe that people with schizophrenia are likely or very likely to do something violent against other people. Why is that important? Well, partly it's important because it turns out to be wrong. But people act on the basis of what they believe to be true. So if you believe that people with mental illness are really violent or dangerous, you might treat them differently. You might treat them with scorn and want distance from them, and you might reject them. You might support public policies that restrict their liberties in ways that are unwarranted. And in the end, you might discriminate against people, in the distribution of the rights and the benefits and opportunities in our society. How common is violence in the United States? Well, if you live in a town, 100,000 people or so, you would expect to find 511 non-fatal injuries every year, 387 violent crimes, 6 homicides. Nationwide, 1.6 million non-fatal violent injuries and 19,000 homicides. Mental illness, in terms of the facts, here's a study that we just did in Florida a couple of years ago. People with serious mental illnesses who are in the public behavioral health system, they account for about 2.2% of the population, 4.6% of the homicides, and 4% of the violent crimes. So in terms of the proportion, it's very small. If we just go to a population of people we know are violent, people who have been convicted of a violent crime and are sentenced and convicted and are in a state prison, and figure out if they're mentally ill or not, about 16% are mentally ill. And by comparison, 18% of the general population has some kind of a mental illness. There are a lot of people with mental illnesses in the criminal justice system, as I mentioned. Here's a pie chart representing the things that people get arrested for who have a mental illness in Connecticut. And what you can see there is that only 10% are for violent offenses. 1% are weapons charges. The biggest category is sort of miscellaneous minor offenses like trespassing and breach of the peace and that sort of thing. And this might be because someone has a mental illness that just impairs their ability to function in society and they run afoul of the law. But we can't conclude that because there are lots of people in the criminal justice system that they're there because they are violent. What about people we already know have a serious mental illness? They have been diagnosed with schizophrenia, hospitalized, and discharged. Let's study them and find out how many of them are violent. This is a study that the United States government, National Institute of Mental Health, funded of about 1,500 people with schizophrenia. And that's all of them. And the little maroon wedge there is 4%. That's the proportion of them that committed some kind of a serious violent act, causing an injury or using a weapon. Another 16% committed some kind of a minor act of violence, simple assault, not causing an injury or using a weapon. So 80% were not. How are firearms related to violence from a public health perspective? What do guns have to do with anything? Well, a big picture, since the beginning of our century, 1.7 million people have been injured with firearms, and over 500,000 have died. And that's a total that surpasses the combined American military combat death toll of World War I and World War II in the 20th century, just to put that in perspective. 59%, of those gun deaths are suicides, people who died at their own hand. 37% are homicides, 4% are law enforcement actions or unintentional injuries or incidents of undetermined intent. Public mass shootings get lots of attention, but they account for less than 0.5% of the homicides. What does mental illness have to do with this? Well, people with a known mental illness account for about 50% of suicides, only 3% of homicides. We need to reckon with the role of firearms in our culture, in our society. We live in a country where guns are part of our culture. And firearms are wrapped up in the iconography of our social history. Firearms and private gun ownership are supported by very powerful corporate interests and political interests. We love guns in this country, and we have a heck of a lot of them. 310 million firearms in private hands. They're not evenly distributed. Some parts of the country have more guns than others. Why do Americans own guns? Here's the answer from a survey in 1994. 52% of Americans who own guns said they own guns for hunting and recreation and collecting, and 48% said they own them primarily for personal protection. All right, same survey question in 2015. Okay, and there we have. Some things never change. There's Sylvester Stallone. Now, 24% say they own guns for hunting, recreation, and collecting, and 76% say they own guns for personal protection. Idea that we need guns in more places, in the hands of more people to keep us safer has migrated into the mainstream. And you hear political candidates, lawmakers, leaders say that this is what we need to do. The evidence doesn't really support that. There's good evidence that there's a strong relationship between the saturation of guns and the firearm-related fatality rate. We have more guns overall, even though the overall rate of gun ownership is going down. More women own guns. We have more sort of super owners, people who have big, big collections of guns. Does this make any difference? Well, let me answer that by making some international comparisons. Okay, so I've selected 15 countries here that they're high-income, industrialized, advanced countries that we like to compare ourselves to. These are countries in Western Europe and Canada and Australia and the UK and Japan. And what's displayed here in these bar graphs, the sort of salmon-colored ones represent nonviolent crime, and the maroon ones represent violent crime. And these are survey data. What percentage of the population in these countries has experienced victimization, crime victimization in the past year? And what's remarkable here is just how average the United States of America is. It's just right there in the middle. Violent crime rate, the average is 6.3%, and the United States is 5.5%. So we don't have an exceptional crime problem compared to these other countries. But now let me show you something else. Let's focus on one particular kind of crime. And I'm going to show you the same 15 countries, and that crime is homicide, where there is an assault and a fatality, a dead body. And I've only put 14 countries on there. I'm going to add the final one for dramatic effect in a minute. But what you see here is this is a rate per 100,000. If you lived in a town of 100,000 people, you'd expect to read the newspaper at one time every year that someone has been murdered, one homicide, or between 1 and 2. That's the average. And here's our homicide rate. It's several times higher, and it's gone down a lot, but it's still higher. So there's kind of a paradox here. How can we have a crime rate that's not exceptional and a homicide rate that really is exceptional? And the answer really has to do with our unique relationship to firearms, because the same surveys show that on average, when there's an assault in the United States, it's about 3 times more likely to involve a gun. And of course, the involvement of a gun is often the factor that makes it lethal, makes it fatal. And if you just think about this for a minute, imagine 3 immature, impulsive, intoxicated young men who come out of a pub in the UK and they get into an argument over somebody's girlfriend in the middle of the night, and what happens? Somebody gets a black eye or a bloody nose. Same scenario, same 3 young men in one of our big cities in the United States. It's statistically more likely that one of them will have a handgun and will use it, and there will be a fatality, and maybe more. Many, many homicides in this country begin as arguments that escalate. The average gun ownership rate in these other countries is about 17 guns for every 100 people, about 17%. And in our country is 97 guns per 100 people. So we have a lot more guns. And all these countries have asked themselves, do individuals have a constitutional right to possess a handgun or a firearm of any kind for their personal protection? And they've all answered that question, no. And we've answered that question, yes. Now, we've actually tried the approach that these other countries use. Think of this as kind of the heart rate of our nation's capital. These are data from the District of Columbia, and they represent the numbers of homicides and suicides without a gun. Those are the blue ones, and with a gun, that's the red one. And you can see here, kind of with the naked eye, that There's no change over there in the homicides without a gun when you go from 1968 to 78 to 88. But there's a significant lurch downward right in the middle of this time series for the homicides with a gun, a decline of 25%, statistically significant in gun homicides, and a decline of 23% in gun suicides. So what happened? What might account for that? Well, there was right in the middle here a sort of a policy shock. There was a very restrictive gun licensing law that was passed for the DC that effectively it made handguns unlicensable. So it amounted to a ban, and there was no effect in the homicides and suicides without a gun. They did the exact same analysis, by the way, in the neighboring jurisdictions of Maryland and Virginia, and they did not find this pattern. It was confined to the District of Columbia that was subject to the law. And they calculated that this law saved 42 lives every year. And you might think that should be the breaking news, but it's not. There's a much more significant news flash that emerged from this story, and it's this, that the United States Supreme Court ruled was unconstitutional, struck it down. This decision was extended to the states a couple of years later. The D.C. case is the famous D.C. versus Heller case, and the other one is McDonald versus Chicago in a couple of years later. And so basically, we put it this way. It would be nice, I think, if we could start with a blank slate, just get a bunch of really smart people together at Westmont College one afternoon and say, let's do what works. Let's just figure out how we solve this problem. What kind of policy should we have? Should we do what other countries do that say the idea that everybody should be able to walk around with a handgun is just too dangerous, so we're going to broadly limit legal access to guns, make exceptions for people on the margins, or are we going to do it the other way around? Well, this isn't actually where we're starting. We're starting here with a constitutional right, this landmark decision I've just mentioned of the Heller decision and the McDonald decision that affirmed that the Second Amendment confers an individual right to keep and bear arms. And whether you think that's what the Second Amendment meant or not, that's what the law of the land is now. And so that is the world that we are living in. But it's also very important, I think equally important, that in Justice Scalia's opinion, he said very clearly, the right is not unlimited, and explicitly preserved certain restrictions that applied to people with felony convictions, people with mental health adjudications like involuntary civil commitment, or somebody you've been found by a court, legal authority to be dangerous or incompetent to manage your own affairs, or in a criminal matter, incompetent to stand trial or not guilty by reason of insanity. These categories have something to do with dangerousness, and there's also a sort of a legal due process issue because there's been a court proceeding with the opportunity for the person to be represented by counsel. So, in my view, we don't really have gun control in our country. It's more like people control now, right? We can't broadly limit legal access to guns. We have to do something more difficult. That's to figure out who are the people who are so dangerous that it is justified to limit their constitutional right. That's really hard to do, because violence is complicated. People are complicated. Violence is caused by many different things. The risk factors for it are nonspecific. They tend to apply to many more people who are not going to do the thing you're trying to prevent. But that's what we have to struggle with. So when do we think about gun violence in our country? We tend to think about it. It seeps into our public imagination, in our national conversation, when there is a horrifying mass casualty shooting by a troubled young man. And it's so disturbing, it's so frightening, it's so irrational. It's an existential threat to us. A mass shooting is just everything we don't want ordinary life to be. We want our lives to be safe and to make sense and to be predictable. And a mass shooting is none of those things. You think about going to a theater or being in a school or a church, a house of worship, and someone comes in and opens fire and people die. And we want to know, why did this happen? What's the answer to this? It just feels so personal. And we get an answer. We get an answer from our political leaders after a mass shooting. And what's the answer? The answer is, it's mental illness. That's the reason for it, right? It's mental health. And it's very oversimplified. Here's just an example. The president, after the November 2017 shooting at the church I think mental health is your problem. This isn't a gun situation. Another example, Senator Joni Ernst, after the Parkland shooting in the school there, stated almost immediately, the root cause is not that we have the Second Amendment, it's that we're not adequately addressing mental illness across the United States. We need to focus on that. Right, and I think if you went out and asked somebody, why do we have this law here? 18 U.S.C. 922D that says that these people can't have guns. If they've been committed to a mental institution or adjudicated as a mental defective, that's the term. It's I don't like it. It doesn't mean anything clinically. Legally, that's what it means, that there's a legal authority that's determined this. So why do we have these laws connected to mental illness? I think people would say, well, we have these laws to prevent these kinds of people from getting their hands on a gun. Gerald Lofter or Adam Lanza, or James Holmes, these kinds of mass shooters. And the problem with thinking about it that way, can these laws keep guns out of the hands of people like this? When people with mental illness actually look like this, like everybody in this room. People with mental illness are people. They have all the same risk and protective factors for violence that you or I do. And they might range from your harmless grandmother to your neighbor's not so harmless intoxicated boyfriend and everything in between. When we describe mass shooters, and there are a number of studies like this. This is an older one by Reed Malloy from University of California, San Diego, who described, sort of profiled 34 young men who had killed at least 3 people in a single event. 70% of them were described as a loner. 61.5% had substance abuse problems, weapons preoccupation. Only 23%, or 1 in 4, had a documented psychiatric history, and 6% were psychotic at the time. Now, more recently, these are data from the open source Mother Jones Guide to Mass Shootings in America. The red bar is the count of the people who, according to the media reports, actually had a mental illness like schizophrenia or something like that, and the gray are people where there was no mental illness known about this person. And what you can see in this 5-year period from 2008 to 2012, 14 of those individuals did have a mental illness, and 4 did not. In the 5-year period from 2013 to 2017, there's been a big increase in the number of these mass shootings, but all of the increase is accounted for in that group that doesn't have an identified mental illness. Right? And so it makes you wonder, is there some kind of a cultural script where these angry, alienated, troubled young men where do they get the idea, where does somebody get the idea that you can get a semi-automatic firearm and go shoot a bunch of strangers and you're going to become a notorious anti-hero? There are young people who are curating these, stories of mass shooters who do not have a diagnosable mental illness. That's, in a way, a much more troubling, actually, problem to think about, because it isn't so simple as saying, let's just fix the mental health care system. I think that's a big dodge to avoid having to talk about firearms, actually. We've known for decades that serious mental illness contributes very little to overall violence in society. This is a study that I and my colleagues published back in the 90s from the Epidemiology Catchment Area Survey. And that little red wedge there, 4%, that's the attributable risk of all the violent actions. In other words, that means is if we had a perfect mental health care system and we cured schizophrenia and bipolar disorder and major depression, which would be wonderful, but our violence problem would go down by 4%, and 96% of it would still be there. So it isn't that there's no relationship at all. The absolute risk is 7%, relative risk is 3.5, but it isn't the place you'd start from a public health point of view to say, let's solve the problem of violence in society. Meanwhile, violence is caused by all these other things. Part of it is demographic, being young and male. If we could do something about maleness, we could really reduce violence in society. I actually made that point once when I was giving a speech to a group of about 300 social workers out in Nebraska. And I just happened to notice, as I said it, that about 85% of the social workers there were women, because it's so I said, and it looks like the social workers in Nebraska have already accomplished that goal. The women liked it, the men thought it wasn't so funny. But poverty and all of the social pathologies that go with that. Childhood maltreatment. When little kids are growing up and they should be establishing an intact personality and they're being beaten and, mistreated by the adults that they should trust. That's bad. It portends a bad course when people grow up. I mean, many kids are really resilient and can overcome it, but too many don't. And, they learn this kind of maladaptive response to conflict and trauma. And so when you say, well, in order to reduce violence, we need to actually have healthier communities with fewer kids exposed to trauma who might grow up to be perpetrators. That's not so simple, and it's not as easy as saying, let's give someone a good mood stabilizer drug, right? Exposure to violence in the environment, impulsive anger, drugs and alcohol is a big one. If we could reduce substance abuse, we would reduce about 35%, 34% of the violence problem. That part of that is pharmacological. Intoxicating substances can disinhibit violent impulses, and part of it might be social, that people who are involved in illegal drug markets, for example, are exposed to unsavory characters and violence. So it's a lot of these things. If you take it's kind of the lowest risk profile, an older woman who's of middle to upper socioeconomic status in terms of education and occupational prestige and employment, and doesn't have a serious mental illness, doesn't have any substance abuse problem, has never been psychiatrically hospitalized, and doesn't have an arrest history, their risk of violence is less than 1%. It's even way lower than the general population. And by the way, I was showing this slide once when I gave a talk in the federal courthouse in Phoenix, sponsored by the Sandra Day O'Connor Law School, and retired Justice O'Connor she actually introduced the meeting and was sitting right here, it was about where Dr. Taylor is. And I was going to say, because I thought this would be funny, in other words, the state of the art of risk assessment technology in our field will tell us that Justice O'Connor here is not going to commit an act of mayhem this year because she fits that profile very well. But she has this aura. She's just looking right at me. And I was like a little kid who climbed up the high dive, the diving board, and I got out and I looked down and I couldn't look up. So I kind of had to unwind the joke a little bit and didn't actually say it, but she knew where I was going with it. And she shook my hand afterwards and said, that was just great, So, and the law professor said, oh, you handled that well. You didn't actually, diss a retired Supreme Court justice. But if we take the photographic negative of this, a person who is younger, male, lower socioeconomic status, has a serious mental illness and a co-occurring substance abuse problem, and has been both hospitalized and arrested, now the statistical predicted probability is 65% that person will do something violent. And all of these things contribute. So what we know is that violence risk is multi-causal, it's cumulative. Violence risk associated with psychopathology is intertwined with and embedded in all these other factors. Now, there are certain times in the career of a person with mental illness where we know that violence is elevated, risk is elevated. And what we have here, these bar graphs represent a meta-analysis of many different studies that have estimated the prevalence of violence in people with mental illness, and they're organized by the settings in which the studies have been done. So you can see there, for comparison, the general population, about 2% of those people are violent in a year, and outpatients in treatment, 8%, representative community samples, 10%. Now, when we move over to the right-hand side of the graph, and we look at studies that have been done in settings where people encounter the mental health care system in a crisis, now the rates go up a little bit. Emergency departments, 23%. That's not so surprising, because maybe that's why people are brought to emergency departments, if there's a risk there. Involuntarily committed patients. Well, danger to others is embedded in the criteria legally for inpatient commitment, so that shouldn't surprise us. First episode psychosis patients. People who have an emerging psychotic illness and they haven't ever presented for care, and they're not even in the system. So, if we are looking for them by looking at records and trying to find red flags, they're not even going to be identified. These could be the same people at different stages in treatment. So, here's a question. Can psychiatrists accurately predict rare acts of serious violence? Well, I'm not a psychiatrist, but I can do it. It's pretty easy, and so can Jim Taylor. It's all you need is this remarkable device called a Retrospective Scope. And it's amazing what you can see through this thing. It's just incredible. And I'm going to show you how it works, okay? Here is a kind of a mass shooting, and it's blurry. We can't tell what's going on here. But we just point the retrospective scope at it, and it sharpens right up. And we get a picture of an angry, alienated, isolated, emotionally unstable young man. Well, that's wonderful. Now we know. And we're just going to take that and turn this device around and point it into the future and find that guy. And we're going to intervene. And for heaven's sakes, make sure he doesn't have a gun in his hand. Okay, so here we go. Now, but maybe it's that one. Right? Or maybe it's that one, because there are tens of thousands of angry, alienated, troubled young men, and you can't just round them all up. You know, those are what we call non-specific risk factors. Psychiatrists' positive predictions of violence accuracy is 41%. They're better at ruling out who's not going to be violent, but when they predict someone's going to be violent, it's right about 41% of the time. We have these three intersecting circles here: suicidality, interpersonal violence, and mental illness. They're not isomorphic. They're not the same. We have lots of people who are suicidal and violent, not mentally ill. A lot of people who are mentally ill and are certainly not violent. And this is what our federal law does. The criteria in the 1968 Gun Control Act that says who can't have a gun. Gun purchase restrictions at the point of sale. And you can see, if you look at how that dotted yellow circle is situated there, what the problem is, right? It's too broad and too narrow at the same time, right? It's under-inclusive and over-inclusive. It identifies lots of people who are prohibited from guns, who are never going to hurt anybody, and they can't buy guns. And it fails to identify a lot of people who really are at risk, right? Here's an example of how the criteria are just a little too broad, okay? Over-inclusive, right? So there's a man by the name of Charles Tyler who was hospitalized when he was 23 years old after his wife had left him and depleted his finances, and he was so distraught, he was saying things about wanting to harm himself, and he was hospitalized. He didn't want to be there. But he got better. He got out, and he didn't suffer from any depression afterwards. He didn't have any problem with drugs or alcohol. He never committed a crime. He had a job. He was employed. And then in 2011, Mr. Tyler decided to try to buy a gun, and he failed the background check because of that incident, that involuntary commitment record that was way back when he was 23, 1985. And he said, "Oh, wait a minute. I'm not mentally ill. I'm a law-abiding citizen. This can't be right." He tried to get a gun, and Michigan did not have any avenue for him to get his gun rights restored. So this legal case was appealed, and it was decided in the Sixth Circuit Court of Appeals. And basically, the court agreed with him. And the opinion from Chief Judge Danny Boggs went like this: the government's interest in keeping firearms out of the hands of the mentally ill is not sufficiently related to depriving the mentally healthy who had a distant episode of commitment of their constitutional right. In other words, just because somebody has this record in their early life, that can't stand as a proxy, a presumption that they are going to be risky forever. We would be giving Congress the right to say nobody ever recovers from mental illness. And actually, the value of that as a risk indicator decays over time as we go out further. Now, here's an example of how I think categorical gun restrictions are too narrow. This is what 100,000 people look like. And we've done a study with Ron Kessler at Harvard to estimate the prevalence of two things coming together. One is impulsive, angry behavior, people who have a really short fuse and have access to guns. Okay, now in that group, that's going to be about 9,000 people in that big crowd. And they have this combination of impulsive, angry behavior and access to guns, and about 1,500 of them will be carrying a gun around with them. Now, and we think that's a bad combination. It's kind of hard to talk about anger as a criterion for thinking about, limiting someone's right to have a gun, because anger is a normal human emotion. Everybody gets angry. Everybody should get angry. Now when I get angry, it's called righteous indignation. But when these people get angry, they break and smash things. They get into physical fights. It's anger that's uncontrolled, that's destructive. Okay, and are they mentally ill? Well, it kind of depends on your definition. A bunch of them do meet criteria for things like personality disorders and substance abuse problems. They don't tend to have these major, psychiatric disorders like schizophrenia that characterize people who are going to get involuntarily committed and lose their gun rights in that way. Only, 10%, under 10% have ever been hospitalized for a mental health problem. But many of them do have misdemeanor violent crime convictions. And in many states, that does not take away somebody's right to have a gun. In California, it does. There's been research done in California by my colleague, Garen Wintemute at UC Davis, showing that that actually reduces gun violence. And it's a policy opportunity for other states to do that too. The best predictor of future violence is previous violent behavior. It doesn't explain it, but it does help to predict it. And violence can escalate. Today's black eye, it can become tomorrow's dead body. Here's another interesting example of how the categorical gun restrictions may be too narrow. This represents a group of 50 people that we studied in Florida who ended their own life with a gun suicides. And we looked at their gun prohibited status at the time. On the day they used a gun to end their life, 72% of them were legally eligible to purchase a gun. They would have passed a background check just fine. You could say, hey, let's have better background checks. They'd pass a background check. We don't have a good enough crystal ball to identify those people, as a system. 28% of them were already prohibited from having a gun, and they got a gun anyway, right? So that's a problem with the enforcement and the implementation of the laws that we already have. That's different. Interestingly, about half of those gun-eligible people who used a gun to end their life had a history of a short-term involuntary hold. They had had a mental health crisis. They had been identified, detained, transported, treated for about 72 hours or less, and then released. But it didn't progress to a gun-disqualifying involuntary commitment. About half the states actually say, well, let's at least temporarily limit access to guns for people who have a short-term hold. We know that they've had a mental health crisis. We have good evidence that that relates to suicidality. Let me say some things about suicide, actually, which, that's the majority of gun deaths. We think of suicide as kind of like that, what appears to be a block of ice floating on the surface of the ocean. It's what we can see, it's what we can count, 44,193 people in 2015. But what we know about the epidemiology of suicidal behavior is it really is much more like this big iceberg here, where we have 9.4 million people who seriously consider suicide, and 1.1 million who attempt suicide, and 376,000 who are treated in hospital emergency departments for intentional self-harm injuries, and 111,000 who are hospitalized for suicidal behavior. And of course, the point with our public health policy would be to let's make sure that we can keep more people down in that part of the iceberg and not move up to where their life is gone and they don't have any second chance. Now, interestingly, when people try to end their own life, on average, 90% survive and 10% die. But there's one major exception to that, and that is if they use a gun. And if they use a firearm to try to end their own life, we have to take that whole iceberg and flip it upside down, because 10% survive and 90% die. People aim at the brain, and it's a massive catastrophic injury to the brain. People die right away. So that's an important public health opportunity. Of course, we should do a lot to reduce the social and psychological determinants of suicidal behavior. But even if we did nothing but change the distribution of methods that people have available or accessible, our suicide rate would go way, way down. For example, if we use the same methods of suicide on average that Canada does, our rate would go down. So let's think about a particularly, I think, interesting and promising policy, risk-based firearm removal laws. They're called by a lot of different things. You might have heard the term red flag law. I don't really like that term, but it's gotten a lot of currency. A gun violence restraining order, that's what was passed here, that the Wilcoxes advocated for. Different names, but common elements of it. It's a civil court order that gives police officers the clear legal authority and gives family members something to do. This could be, we're really worried about granddad. He's bereaved. He's all by himself. He's drinking heavily. He has a lot of guns. And we're worried about him. What do we do? Well, in many states there's nothing to do. Granddad hasn't committed a crime. It's his right to have those guns. He's not mentally incompetent. He's not criminally accused. Now, in 13 states, including California, there is something you can do. You can either directly go to a judge and have the judge, under certain criteria, issue a risk warrant to have granddad's guns taken away, or you can use law enforcement as an avenue to do that. It's temporary, it's preemptive, it's a public safety measure. Then there's a court hearing, so there's due process. It's a kind of thing that there's a lot of public support for, even among gun owners. The majority of gun owners support this because it doesn't affect law-abiding gun owners. It just affects people who have, some important evidence that they're risky. There were, before 2013, only 2 states that had this. Connecticut is one and Indiana is the other. Both of them were enacted in the aftermath of mass shootings out of public concern. But as they were used, actually suicide concerns was the highest category of cases where it was used. Now, in 2018, we have 13 states, and a lot of this has been because of advocacy and taking evidence. We conducted the first empirical evaluation of how these laws worked, and I'm going to tell you about that in a minute. Our study took the 762 cases of gun removal in Connecticut, and the average number of guns removed in each case was 7 guns per person. So these are people who had a lot of firearms, mostly men across the age spectrum. We matched them to mental health records and found out that almost half of them had a record with the public behavioral health system, the Department of Mental Health and Addiction Services in Connecticut. Only 12% had an arrest, during the year before or after. 61% of these cases was a concern about risk of harm to self, sometimes both, but it's to self. And the calls came from family and acquaintances in 49% of the cases. In many cases, when the police arrived to execute this risk warrant and take guns away, they found a person in a crisis and took them to the hospital. And so people actually got treatment. And from the year before to the year after, the proportion of people who got treatment after this gun removal doubled from 12% to 29%. We matched these cases to death records, and I, thought we wouldn't be able to find anything because we had 762 people in our study, and the population suicide rate is 12 per 100,000, so I didn't think that we had enough cases to show anything, but we found that 21 of these individuals went on to take their own life after the gun removal. None of those happened during the year when the guns had been removed. They all happened after the person became eligible to get their guns back. Very, very few of them actually used guns. They used other methods for the most part. That's a rate of 40 times higher than the population risk. That's important, I think, politically and legally, because it shows that we're not just applying this willy-nilly to take guns away from people. It's not this broad confiscation scheme. It's focused on people at risk, right? If you're a Second Amendment person and you say, guns don't kill people, people kill people. Well, here's a law designed to tell you who those people are, to use information that people have around a person to say, let's do this for their own good. What we were able to do is to estimate, using a little bit of algebra, how many attempts there were to produce those 21 suicides by those particular methods. Because we have good information about the case lethality rate. We know what the probability is if someone uses a rope to try to end their own life. What's the probability that they're going to die or survive? And so what we were able to calculate is how many attempts there were, and then we did this kind of counterfactual analysis. What if the guns had not been taken away, right? How many more people might have died? And putting that into the model. And based on the assumption, we determined that somewhere between, for every 10 to 20 of these gun removal actions, 1 life was saved. Now, is that high or low? Well, it might depend on where you're standing, right? If you're someone who cares more about the Second Amendment right than anything else, you might think that's unacceptable. You know, if you're someone like, I don't know, many people who are no more than 1 or 2 degrees of separation away from a gun suicide in your own family, in your circle of friends and acquaintances, you might think about it differently. This is part of the reason I'm passionate about this issue. It is part of why, you know, our own biographies sometimes become intertwined with things that we care about. You know, people ask me sometimes, what's the one thing we should do to stop gun violence? It's not a one thing problem. It's not a one thing solution. We need to do a lot of things. I mean, there are the social determinants of crime and violence. There's mental illness. There's the point of sale background checks. We need to make that system work better, have more records in there and have it comprehensive. We have what to do about risky people who are not disqualified from guns. What about all the legal issues, the Second Amendment issues after the Heller decision? Gun technology, you know, we could have smart guns, owner recognition technology, a gun that would only work in the hands of its rightful owner. We have illegal gun markets. So many of the guns are exchanged on the secondary market, the illegal market. And maybe we need better enforcement of that. Maybe we need to do something about our culture, right? That's an important purpose of a public health law, is to change cultural norms in a safer direction. Think about suicide as if it were a problem like, motor vehicle crashes, right? Think about the seatbelt laws that were passed and how much resistance there was from manufacturers of cars that didn't want to do that. And now, you know, do you wear your seatbelt because there's a law and you're worried about the law? No, you wear it because it's just natural. You'd feel weird without putting your seatbelt on. And it changed cultural norms. And perhaps, sensible firearm laws that do not run afoul of the Second Amendment could do the same thing. Mass shootings are a different, sort of uniquely American problem, although, you know, we've just had this terrible incident in New Zealand. So all of these things, you know, I believe, I'm in this for the long haul, and I think we will one day live in a less violent society, and we will live in a world where we have fewer mass shootings and fewer people dying every day. On the day of a mass shooting, 100 other people die, you know, throughout the United States that we don't hear about, right? That's the drip, drip, drip of gun violence and intimate partner incidents and gang shootings, suicide. I think one day we'll get there. And there's not going to be a big headline in the LA Times that day that says, reduction of social determinants of violence and better background checks and better access to mental health care treatment prevented mayhem on Thursday, right? We don't see that. But if we really got there, why would that matter? Thank you very much.